Welcome to Hope Biosciences. Today, we have a very special opportunity to do a deep dive into the world of juvenile idiopathic arthritis. So for our newest clinical trial that is currently enrolling, we want to take this time to educate physicians, patients, caregivers, anybody interested in this topic, to understand how the cells that we are delivering work, and what is the rationale behind the study, the design of the study, and all of the logistics and details in between. So come on in, let's start with the cells. So in this video, you will hear the term investigational product, drug, stem cells, all referring to the same thing. In this trial, we are going to be using allogeneic mesenchymal stem cells that have been derived and isolated and culture expanded or grown from a single donor. So what are mesenchymal stem cells? MSCs, for short, are naturally occurring cells within our bodies. Now, practically every tissue in our bodies contains these very powerful stem cells. Now, a stem cell, by definition, is a cell that doesn't have any identity. It's a cell that needs to be triggered to become a different tissue. They can transform. That's what they're characteristically known for, their ability to transform into different tissue types, and their ability to regulate inflammation and do a whole slew of other things. Although MSCs are naturally found in the body, the problem when we face disease is that we lose these cells because our bodies are combating that disease constantly on a regular basis. And so because of that, our body's ability to make up for those used cells is drastically diminished. And so what we are trying to do is figure out how we can, in the lab setting, make these cells or proliferate these cells and give them back to the body. So what we're giving back is essentially what the body naturally has to begin with, but again, few in number. So when we give them back in very high numbers, and the dosage in this trial will be weight dependent. So depending on the age and weight of the child, the dosage of the cells will follow a specific regimen. But the dosages we are giving are very high, meaning that we are flooding the body with an army of these cells in hopes that they will perform the mechanisms that they are known to perform. Why are we using mesenchymal stem cells, MSCs for short, to treat JIA? You have to go back to the mechanism of the cells. So MSCs are well known for their ability to differentiate. That basically means their ability to transform into various tissues. So in arthritis, for example, if you need cartilage, MSC can actually become new cartilage. But in this trial, it is more likely the mechanism of the cell's ability to regulate the inflammation in the body, which will cause the desired effect: less pain, less swelling of the joints. So how do these cells do this? In this diagram, you have to ignore the syringe that is going into the joint itself because we're not directly injecting the joints. But if you see here, all of the things that are happening around the joint are the mechanisms of these cells. So it's very complicated. They're doing more than one thing. And unlike a drug, which is typically a single pathway to fixing a disease or impacting a symptom of a disease, MSCs work in all these ways. So it's very difficult to pinpoint exactly what they'll be doing within the joints, but when introduced intravenously, so through the bloodstream, these cells will naturally navigate to the areas of the body that are typically inflamed And they do this through what is the homing effect of the body. This happens naturally all the time. We have MSCs floating around in our bodies, and they're responsible for going and fixing and repairing injured sites in our bodies or inflamed sites. So they naturally do this. And more specifically, MSCs can suppress autoreactive T cells, particularly Th1 and Th17 cells, which are elevated in JIA and drive inflammation. So how do they regulate the T cells? They can actually produce Tregs, and the increase of T regulatory cells will decrease the T cells in the body. So that's how they do that. MSCs reduce B cell proliferation, plasma cell differentiation, and autoantibody production, critical because autoantibodies may be involved in some JIA subtypes. When MSCs are introduced systemically, they're traveling through the body, through the bloodstream, and while they're doing this, they're secreting certain factors. They also do this when they arrive at an inflamed site, for example. What kind of things are they secreting? MSCs will secrete anti-inflammatory cytokines like IL-10, TGF-beta, PGE2, and they'll decrease the production of cytokines like TNF-alpha, IL-1, beta, and IL-6, which are central to JIA pathogenesis. Macrophages, a big word in the world of inflammation. We see it in neuroinflammation, we see it in systemic inflammation. MSCs shift macrophages from a pro-inflammatory M1 phenotype to an anti-inflammatory M2 phenotype, reducing tissue damage in joints. So how quickly do these cells work? Because of the fact that we're delivering the cells intravenously, as they're traveling through the body, they are secreting very powerful anti-inflammatory agents. And this can result in almost an immediate effect of pain relief, but really cells do take time to work. And different from a drug, where you take a drug and you see an immediate benefit and it wears off over time, MSCs we've observed are very different. Normally, effects take time to show up, and we will see the full result months after the administration of the first dose. So now that you know everything about the cells, why don't we take a peek upstairs and see how they're made? So welcome to manufacturing. This is the facility right here in Sugar Land in the same building where we produce and process the cells for the trial. In this trial, we are going to be using one designated donor, and the purpose of this is so that the children won't have to go through the process of isolating their own cells. But again, what we're giving back are isolated and culture expanded, so cells that have been in the lab, taken and grown. So we're increasing the number of these cells dramatically and delivered back into the patient right downstairs. So cells will be ready to infuse, and they'll be taken right down the steps into the infusion suite at the Hope Biosciences Research Foundation. So let's go back down and we'll take a look at where cells will be delivered and have a good discussion with some of our team members on the foundation. Okay, so we have the cells, they're down here, and they're delivered right here at the Hope Biosciences Research Foundation Infusion Suite. This is a clinical research site that has all the approvals necessary to conduct the research that we are doing. If we go in here, this is what we call mission control. In mission control, we do all of the clinical research protocol development as well as all the reporting. And there we have Radima Vij, and Radima will be doing all of the statistics and the planning surrounding the trial, and also the readouts at the end, and including all the manuscripts that are written at the conclusion of the trial. So, Dr. Vij, you have time to join us today? Sure. Okay. So I think we need one more person to join us, and that would be the sub-I for this protocol, and it's none other than Michelle Vedran. She has her doctorate and is a nurse practitioner with the Hope Biosciences Research Foundation. and she'll be doing all the clinical assessments and is the perfect person to join us on our deep dive.
Hello, nice to meet you.
So we are incredibly excited to begin our first clinical trial for a pediatric study. And of all things, it's juvenile idiopathic arthritis. Ridhima, why don't we first kind of go over the history? How do we get here?
Sure. So basically, I was pretty new when I joined Hope, and I was given a bunch of data from our successful completion of our RA study. Remember, that was the first ever study I analyzed, and looking at the data, I was amazed to see that the efficacy was robust, and same was the case with the safety. So it was an open label, no control study, and we evaluated safety and efficacy of a single dose of 200 million cells of adipose-derived mesenchymal stem cells. And the study was conducted like over the period of 52 weeks. There were like several follow-ups, both accumulating safety and efficacy. And when we looked at the efficacy, we saw that there was statistically significant results both in swollen and tender joint counts. And also we looked at the inflammatory markers like CRP, TNF-alpha, IL-6, which also showed promising results, at least clinically, if not statistically significant. The efficacy in the clinical joint counts and in the swollen and tender joint counts, it was pretty robust, both statistically significant as well as we saw clinically meaningful implications in reducing the pain and inflammation of joints. The safety was robust as well. We looked at the laboratory markers like hematology, renal, and hepatic functions. Those were all within range. There were no changes. And also there were like minimal adverse effects. Those were transient, and there were no deaths reported in the study, which was great. And also the SAEs that occurred during the study, they were resolved within the study. They were not long-term SAEs.
And SAEs are severe adverse events.
They were severe adverse events, but none were related to the investigational product. So none were related to the administration of our infusion.
Okay. And for those new to the clinical trial world, adverse events and serious adverse events are any events that occur during the conduct of a study. So while a patient is enrolled in a study, even if they trip falling somewhere and breaks a leg, that is an adverse event.
That was one such event during this study. I remember there was a fall and where the patient has to be hospitalized, but then that has nothing to do with the administration of the product.
So we track these adverse events. First, we have to make sure we document every single thing. So if a patient gets the flu in the trial, that is documented as an adverse event. But we have to go through correlation to make sure we understand the relationship between the drug and those kinds of adverse events. So from what we measured in rheumatoid arthritis, at least in the adult study that we're talking about here, we did not observe any treatment emergence. So
they were not treatment related. So any SAE that we did see, that was not treatment related at all.
Were there any safety issues or any side effects that were observed in the adult study?
Not really. So the mild adverse effects that we saw, they were like flu-like symptoms, which included fever, chills, or headaches. But those were like resolved by taking like a couple doses of Tylenol. So those were like pretty mild adverse effects we did see with the adult population.
All right. Well, so with that, we were excited about the results. And with pediatric studies, which we've tried in the past with not a lot of luck, we have to show something called prospective direct benefit, PDB. And that's the only way FDA will consider us going into a pediatric study. So that data was instrumental in fulfilling that requirement. And so here we are now.
So we are very excited that we are able to conduct our first clinical pediatric study right here at our facility in Sugar Land, which is just a suburb of Houston, Texas. It is free to participate in our study. So any fees or anything that you're worried about receiving the investigational product, that is completely free to the patient. We do partner with an organization called Miracle Flights. We know we do have several participants enrolled in current studies that are from all over the country, everywhere from Florida to Wisconsin to even Hawaii. And Miracle Flights really does help. All you have to do is go to their website, miracleflights.org, and sign up. We get your information, and then we have to do our side of things. And hopefully that will be able to take some of the burden of the travel cost off.
Wonderful. And do you think it covers the entire family? I know that with young kids, the family has to travel together.
Yes, that is one thing that we did take into consideration. It will help, I believe, the participant, will be the child and one parent or guardian.
Okay, wonderful. That's great. Okay, so I think it would be great to go over the design of the trial and why we designed it this way. There are some differences between the adult trial and the pediatric trial. One very obvious difference being the number of doses given. So in the adult trial, we only gave a single dose. And Rudima, when we actually conducted the trial, I know both of you weren't here at the time, I can tell you that when we submitted the request to FDA for the adult trial, we actually submitted the request for 3 treatments, just like we're doing for juvenile arthritis, And FDA at the time kindly said no, because we had never conducted a full-on trial before using the cells that we made. And so FDA required that we first conduct a study with a single infusion, and that we could do a future study with more. And now, after many years, we have some protocols that are upwards of 20, 30 infusions. And so we've come a long way since then. But for this one, we did, off the bat, ask for 3, and we did get that. And so, why don't we talk about the study?
So basically, after the success from a single dose of cells in our RA study, and with the success we saw in efficacy and safety profiling was robust, I think it was good to do like the multiple infusions now, since we have like the all across data from different indications now. So multiple infusions are safe and efficacious. So talking about the scheduling here a little bit about this JIA trial. So post-screening, we will randomize the subjects and patients into 2 different groups, Group A, B. So it's a crossover study. So it's a Group AB and Group BA. So Group AB will receive 3 IV infusions of cells every 4 weeks. I would like to point it out that the monthly infusions from our previous data from different indications, we saw monthly infusions are far more efficacious than any other schedule. So I think we will stick with this for this study to bring the best results. And so the schedule, it looks like they'll get 3 infusions every month. That is first infusion at week 0, second infusion at week 4, and then at week 8, and the third infusion at week 8 with a and then we'll be doing a safety follow-up at in another 4 weeks at like week 12, and which is followed up by the washout period of 8 weeks, so that we make sure that there are no effects from the previous treatments in the subsequent. There are no effects from the previous treatments in the subsequent treatments. So, and then the crossover group BA would receive these 3 infusions in a similar pattern, monthly infusions. So that's pretty much the schedule is. But before we are actually doing the whole bunch of this schedule with the whole population of our enrolled patients, we'll first do just the bigger kids in a small cohort. We'll just enroll like 6 kids, and they'll get 3 monthly infusions, a similar schedule, and then they'll be looked for the safety first, and after we get like a green signal from our DSMB and FDA, we'll be proceeding with our rest of the 60 patients with the schedule I just discussed.
To recap, all the patients in this study will receive the stem cells, so the drug that we're talking about. And a crossover design means that they will all receive it, but not at the same time. So one group will go first and the second group will go next, but you will not know.
Correct.
The patients and you, the assessor and everyone will
if
not
double
know
blinded,
who is in what group.
Right. So we take different information from the screening, such as their scores, their blood levels, their age, different demographic information, and that's how the patient will be randomized. Again, no one knows which group the patient is randomized in. None of the clinical people or any of the data team, nobody knows except the one unblinded mixer is what the person is called. And we just tell them, hey, patient 001 is here. They deliver the product, and we have no idea whether it's the placebo, which is normal saline. It's just normal saline is what you would get in the hospital if you go for dehydration or pretty much anything. Everyone's given normal saline, and we wanted to make sure that it was safe as possible. So just like any other pediatric medication, this is all based on the patient's weight. So everything is based on how many kilograms the patient weighs, is how many cells and how many milliliters of normal saline they'll receive.
So how many visits are the families committing to?
So there is 3 infusions, and then, like Radima mentioned, a washout period, which is just like phone follow-ups. And again, we don't know if it's 3 infusions of the stem cell, which is our investigational product, or 3 infusions of the placebo, and then again, the washout period, and then 3 more. And then they will have, I believe it's 4 follow-ups.
There are 4 follow-ups after the infusions are
After
done.
the infusions are complete, that the participant will need to come back here in order to complete just blood work, and so that I can do their clinical assessment and check their joint counts.
So it looks like there are 11 in-person visits?
So actually it's 12 in-person visits that the patient needs to come back here for. That includes their screening, all of the follow-ups, and both sets of infusions, the placebo and the investigational product infusion. And the reason that every visit is in person is because, mainly for safety, we have to check labs. We check basic labs, make sure that all organ function is good, there's no acute infection, but also to determine their joint count and to determine how the efficacy of the product.
So in the adult study, we measured 2 components. Like you said, the clinical findings, which I think as mom, that's what I would be most like, that would be the reason why I'm enrolling my child, would be to see what are the actual like quality of life benefits. Has their pain decreased? I assume we're going to be measuring the same things in this trial.
Yes, so we are going to be measuring what's called the ACR-PD, which is the American College of Rheumatology pediatric assessment. And we base it on percentages, 30, 50, and 70% improvement. And this is basically just an overall of how the child's doing. So I will do my assessment and grade the child, and then either the patient or the parent, depending on the patient's age, will grade their overall assessment and how they're doing on just daily life. And then also this includes things such as joint count, how many active joints are swollen and tender, how many have limited range of motion. So if the child cannot bend down like a normal 10-year-old or stand up, walk, things like that. And then it also is determined by inflammatory markers, CRP and ESR, which we'll be measuring in the labs to determine the level of inflammation the body has, which is usually very high in JIA cases, especially when there's an acute attack going on.
Is it high even if the patient is on a medication?
In some cases, no, because the medication is, lack of a better term, working. But any kid that has active joint pain and swelling, the ESR and CRP are most likely going to be elevated, even slightly.
And so it's a requirement in this study to be on a stable regimen?
So yes, the patient does have to be on a stable regimen of a minimum of 3 months. And this is just to make sure that the investigational product is being shown to have the best efficacy that it can. We want to make sure that no changes in the treatment regimen are made, because then we won't know if it's the investigational product or a change in the medication or treatment that the participant is doing.
So if the patient is on a stable regimen, would you suspect that their inflammation is still high, as reflected in their joints and in blood work?
The child will be on a stable regimen of a minimum of 3 months. However, the ESR and CRP levels, which are the inflammatory markers, we will expect them to be elevated even slightly, because if the child is still having joint pain, swelling, tenderness, limited range of motion, that means that their joints are inflamed, and that's what's causing all of these symptoms. But we do not want the participant to change their regimen at all. We want them to stay stable. That way we can test efficacy in the best way that we can.
Are there any other assessments that will be performed? Like how will we be measuring success or if the treatment is working?
So like I mentioned before, we will be taking labs, and that would be the inflammatory marker, ESR and CRP. But then I'll also be doing joint counts. So we'll go basically head to toe on every participant, and it changes a little bit by age because of course a 2-year-old cannot do the same things as a 10-year-old can do. So there are some differences, but overall I try to make it as fun as possible. I've worked with kids for several years during my career, and you just want to make it fun. You don't want to make it seem like they're in a doctor's office and it's scary and I'm doing something that's going to hurt them at the end of the day. So there'll be different assessments to like check their fingers. I'm going to say, can you make a claws like a cat? Can you open your mouth wide and say, as big as you can? Touch your ear to your shoulder, things like that to make it fun. Can you walk on your tiptoes, on your heels? Just to incorporate the fun side of what we do also.
Okay.
But then we'll also be doing, it's called the Childhood Health Assessment Questionnaire. And again, depending on the participant's age, it's either going to be done by the parent or the child. And this is just an overall look of how their daily life is. Can they get up out of bed by themselves? Can they take a shower and brush their hair and teeth by themselves? Can they button buttons and tie their shoes? And again, the assessment does differ a little bit because of the ages, but everything is tailored to that child based on their age.
So we have a great overview on trial design, and hopefully we'll be measuring the right things. One thing that we really try to do at the foundation is design what we call patient-centric trials. So it's designed to monitor the well-being of the patient more than our scientific curiosity. And so there's a good balance of that, and hopefully we will have the biomarkers in the blood to match what we see in clinic. Why don't we go through who is allowed to participate? So in any trial you have inclusion, which are the criteria that you must have to enter the trial, and exclusion, which are the criteria that you cannot have, that would exclude you from participation. So the first is for boys and girls who are between 2 and 16.
Yes, so we chose these ages because juvenile arthritis must be diagnosed before the age of 17, so 16 years or younger. When people hear arthritis, they think it's an old person disease, basically, but kids can get it too. And that's why we really wanted to focus our first pediatric trial on this age group, because like I said, it has to be diagnosed at the age of 16 or younger.
What causes this condition?
So it's actually an autoimmune disease. So basically your immune system is attacking the joints that are being affected. So if a child comes in with knee pain and ankle pain, such as seen in oligoarthritis, that means that the inflammation, their immune system is attacking their knee and their ankle.
So they have to be diagnosed with oligoarticular or polyarticular juvenile idiopathic arthritis. What are the differences? What are they?
So these are the two primary types. There are, I believe, 6 subtypes of JIA, and these are 2 of them. Basically, Oli is 4 or less joints, and poly is 5 or more. And these can be any joints in the body, anywhere from your jaw to your wrist, ankle, shoulder, back, any joints at all. All it has to be, and our trial is a minimum of 3 affected joints.
They have to have a documented rheumatoid factor test result in their test records.
The only reason this is because this goes into randomization. We won't do really anything with that information, but that is a very, very common test that the child's rheumatologist will most likely do when they're first diagnosed with it. So every participant should have this test already done.
And so given that these tests have to be done previously, medical records, are medical records required?
Yeah, so we will need access to every participant's rheumatologist records and also their primary. That way we can have an overview. We want to make sure that the child is basically as healthy as possible. We understand that these kids are sick, and some might have other diseases like ulcerative colitis, diabetes, other types of autoimmune diseases, but we want to make sure those are stable and they're not having any acute attacks, because that can alter results. And also, we just want to make sure that the child is as safe as possible.
So records are going to be requested at screening or?
Prior to screening, just so that the clinical team can look through them and just make sure that they meet all the requirements, because we don't want you to take a trip all the way out here if we know by the medical records that for some reason you would not be able to qualify.
You mentioned 3 or more joints affected, and it can be any joints.
Correct.
Okay. All right. They have to weigh more than 10 kilograms?
Yes.
So they must not be on a current treatment for JIA, or if already on treatment, should be a stable dose for at least 3 months.
Yes. So because we understand that, of course, allergic reactions happen and things of that nature, the child does not have to be on any type of treatment regimen, such as methotrexate, which is the most common medication for JIA. But if they are, then they have to be on it for a minimum of 3 months, a stable dose.
They have to have abnormal CRP and or ESR results at screening. Abnormal CRP is a level greater than 1, and abnormal ESR is greater than 15 for boys and greater than 20 for girls.
Correct. And those, again, are just the inflammatory markers that we talked about earlier.
And just out of curiosity, are those thresholds considered high, pretty low?
So anything above the baseline. So that is anything above 1 is considered abnormal. 1 or lower for CRP is a normal level for anybody.
Okay. Female participants should not be pregnant or planning to become pregnant during the study and for 6 months after the last treatment.
That is correct. So we take pregnancy very seriously because we don't know the effects of the investigational product on a potential fetus. Therefore, we do make sure that any female of childbearing age, so basically if they started their menstrual cycle, they will be required to take a pregnancy test before every infusion. We do have a protocol in place in case unexpected pregnancy does occur. We will follow up with that patient for all throughout the pregnancy and for the following first year of the child's life, just to make sure everything is going well and both the patient and their child are safe.
Male participants whose partners can become pregnant should use contraception during the study and for 6 months after the last treatment.
Yes, and again, for the same reasons, it's a little harder to follow up sometimes with males, but again, it'll all be in the informed consent, all about birth control, abstinence, barrier methods, things like that, and the child will need to consent that they understand the rules and the protocols.
So for consent, at what age will the patient themselves consent as opposed to the parents consenting on behalf?
So our actual informed consent, all of the parent or legal guardian will need to do an actual consent. but any child over the 8 or older will need to do what's called an assent, and that's basically the child understanding that what they are agreeing to do, because we never want to put a child in a place that they don't want to receive the investigational product or the lab work, because we understand it can be scary, but 8 years old is when the child becomes knowledgeable enough to understand the basics and can say, yes, I agree to this treatment.
The participants' parents or legal representative must be able and willing to follow the study requirements. Same thing, they'll have to sign a consent before any study related.
Correct.
procedures.
And we are happy to answer any questions or concerns. Prior to this, I've received a couple emails, and we have no problem setting up a teleconference call with them, meeting with any physicians. We're happy to answer any and all questions and concerns.
All right, so we've gone over all the inclusion, and that sounds pretty simple for your participation. The exclusion is slightly longer. There are a lot of exclusions in the study, primarily related to safety. So to start, if the study subject has any one of the following abnormal lab results at screening, white blood cells greater than 15,000, hemoglobin, glucose, potassium, BUN. I won't go over all the levels. We'll have that below, right below here in the caption. We'll have all the inclusion, exclusion. Just overall, why is it important to stay within specific ranges?
We just want to make sure that every participant is as safe as possible to conduct this study. And the FDA agrees with that, and that's why they are very, very specific on lab tests, especially levels like potassium, creatinine, BUN, because any levels that are abnormal, something else is going on. And we never want to put the participant at risk for anything that we might not know about. If their potassium is too high, then that can cause heart issues. And we don't want to put them at risk, and we just want to keep them as safe as possible.
If the study subject has any abnormal vital signs at screening as determined by the doctor, so what?
So if the child comes in and has a fever, then most likely there's some type of an acute illness going on. And we don't want to start the study when something acute other than their arthritis is occurring, because again, that just puts them at risk for possible side effects and serious events.
So if they, for some reason, don't pass screening due to an abnormal value or something like that happening, can they re-screen? Is there...
Yes, so every participant, for whatever reason, if they do fail, can rescreen one time.
Study subject has any serious medical conditions that are not controlled, including conditions like diabetes, Crohn's disease, lupus, multiple sclerosis.
Like I mentioned before, some of these patients might have diabetes or a different autoimmune disease. As long as it's controlled and they're on some type of stable regimen and not having an acute attack during screening, then we're totally happy with that and they're good to go.
If the study subject has any type of active cancer, including certain types of skin cancer, like basal or squamous cell carcinoma or melanoma, all of those.
And again, that's just for safety reasons. We want to keep these kids as safe as we can, and any type of cancer, that needs to be seen by a specialist, and unfortunately they will not be able to participate.
If the study subject has a history of alcohol addiction, substance abuse, or currently struggling with substance abuse.
Yeah, we don't see that as much of a problem in this population because it is kids, but that is something that we always add, because alcohol and addiction comes with a series of possible adverse events. And again, at the end of the day, we're just worried about safety, and that can cause different lab levels to be inactive or abnormal, and it can also cause the patient to become inactive in the trial, and so we just don't want that to happen.
If the study subject has received any stem cell treatment within the last year, if study subject has received any experimental treatment or medication, except for COVID-19 vaccines in the last year.
Yeah, that's in almost every one of our protocols, and that's just to make sure that we're testing the efficacy of our product, and there's no outlying factors of any other investigational product that might be interfering with our results.
If the study subject has any other health issue or lab abnormality that in the doctor's opinion could cause safety concerns or prevent the subject from completing the study. So that's, I guess,
That's kind of a catch-all because we do realize outliers happen, and that's just our way of saying, even though your level is, say, normal, we still don't think it's safe because we found this on the assessment.
Okay. If the study subject or parent legal representatives are unlikely to complete the study or follow the study rules.
Yes, so completion is extremely important in every clinical trial. And that is why we have so many follow-ups so far out. We want to see how the participant is doing after they receive the investigational product. We want to make sure both that how they're feeling and are they still safe. And that's why continuing every single follow-up is very, very important.
So it's not just the treatment.
Correct. It's all the follow-ups that come after.
Yeah. If the study subject has an active or chronic viral infection, such as Hep B, Hep C, or HIV.
Yes, so those infections are chronic, and they can cause different variability in lab levels, illnesses, acute hospitalizations. So if they have any of those, unfortunately, they will not be able to be included.
Last exclusion, if the study subject has a systemic infection that required antibiotics, antivirals, or antifungals in the 30 days before the first dose of the study treatment.
Yeah, so again, that goes back to the acute infection, and we just want to make sure that the child is as safe as possible. This is when it would be up to the clinician's discretion if they can rescreen. So if they have, say, COVID-19 and are on the antiviral, we can wait, make sure they finish the antiviral and they're illness-free, and then they can rescreen and potentially be a participant then.
Well, that is it. So if you meet these requirements, and again, it's all listed here below. You can also call in if you have a question about any one of them in particular, and our clinical staff will be happy to go over them with you. And is there a pre-screening? So if I'm interested and I call in, can I be screened over the phone or?
Unfortunately not. The screening process has to be scheduled and it has to be taken here because, again, we'll do lab work and I will do a complete physical assessment to make sure that the child does have the 3 affected joints, minimum of 3, and also just make sure overall healthy, their lungs, their heart sounds good, and there's no acute infection going on. So unfortunately that does have to be in person.
But to know that I qualify, is there enough that can be done before that screening visit to make sure?
Yes, and that's why we do request the medical records before so that we can go through everything and make sure that the medication regimen and everything is within those parameters that we're needing.
So one of the biggest differences between this trial and the adult trial was in the adult trial, we studied the use of one's own cells. So the 15 patients in the adult study all gave us a fat sample in which cells were then isolated and cultured for that individual from that individual's own cells. In this trial, we decided not to go that route and use a verified donor and it's one selected donor, healthy young donor, that we've isolated some tissue from, isolated cells and cultured, and all the cells that are going to be cultured the same way, and all kids will be receiving the same donor. And this donor has been used in previous studies, and so we know that they produce very consistent, good populations of cells. But I can understand the concern of, well, these are not my child's own cells. These are a donor cell. What are the reasons why we went with a donor cell product in this trial?
One of the biggest reasons was one less procedure for the child to undergo. I myself have a 2.5-year-old, and she is a skinny little thing. She doesn't have much fat on her. So to do a fat extraction, in my mind, on her would be scary for both of us.
Yeah, because that is what's required. The way that these particular, and these are mesenchymal stem cells that are derived from fat tissue, will require a small fat biopsy. Now, from an adult, a tablespoon of fat we can readily find in America with no issues. But given the age group of the kids in this trial, 2-year-old, 2 to 16, the younger ages would have a very hard time with a fat biopsy. Right. So we definitely, I think as moms, we thought, yeah, we can't do this. Right. we shouldn't add this in. I think we originally had it in until we had this moment that we thought about it and really thought about the execution of it and realized that it probably would not be a good idea. And also, how about in terms of safety? If people were concerned between the use of your own cells versus a donor cell and safety, what would be the things to consider?
Overall, I think mesenchymal stem cells from various different clinical trials and other studies, they have demonstrated a strong safety profile. They have low immunogenicity, so the risk of rejections, they are minimal when we are using mesenchymal stem cells. So all the studies, like majority of the studies that I have seen and read about, they have reported, if any, very minimal adverse effects, and they have like the promising benefits in different indications. They could be like autoimmune diseases like SLE or arthritis and things like, and other all like a broad range of different conditions where MSCs, they have demonstrated safety profiling. So I think there are very minimal risks, if any, but their overall efficacy is promising.
We were curious about this. I think early on, when after Hope Bio, developed the technology, and the first trial being rheumatoid arthritis was using autologous cells. After that, when we went into the COVID era, we were helping people with acute COVID in the hospital settings, and none of those people had cells banked. So there was no way to use one's own cells to rescue patients in that scenario. So that was the first time where we had to request for the use of a donor. And yes, papers heavily suggested that there was no possibility of rejection, but without doing the trials and conducting them, we really didn't have an answer to that. So through COVID, we learned that, oh wow, the safety is maintained. There is no rejection that we are seeing using donor cell product. And since then, in Parkinson's and
various neurological diseases like Parkinson's disease, we have I think 6 different trials in PD. We conducted the trial in MS. We successfully completed that one. So safety was never a concern in any of the trials. It can be autoimmune disease like SLE, COVID-19, post-COVID-19 syndrome, and from these neurological diseases, complex diseases like MS and PD. So we have never encountered any safety issues.
Like between using your own cells and donor cells.
Yeah, that as well, yes. So COVID was our Allogeneic trial, meaning we had a healthy donor from where we got the cells, and it was administered over multiple infusions in the patient's cohort, and safety was not a concern at all.
Again, I think the main driver behind the decision here? It could have been either or, because if we're thinking, would we expect that the efficacy of one's own cells be the same as the efficacy of using someone else's?
I don't think there are differences.
Okay.
So none that I know of in the literature search or like from lessons from our own different studies and different indications. We have not seen any differences in autologous, like using the cells from their own body or the ones from the healthy donor. I don't think efficacy would be any different.
Which is really refreshing to think about, because if you just take safety as a concern, the safety between using your own or using a donor's is always like, okay, what would be more safe? But in the efficacy, having a donor cell product that's evenly distributed amongst all the participants seems like, oh, at least you're testing the same medicine across all these patients. So you would expect efficacy to be very even. Whereas if you're using autologous cells and everyone's getting their own, theoretically, they could be all getting a different medicine.
Very true.
And I think that's why the adult trial was so eye-opening, because it was the first time that clear efficacy was demonstrated across all 15 patients, despite the fact that they received their own cells. And you're talking about people who are very sick. So even people who are very sick, who had been sick for a long time, had good stem cells isolated, and their cells were still efficacious in their condition. And so anyway, I think this is a healthy balance without having to expose the child to an unnecessary medical procedure that would be painful for both the child and the parents. Yes. Okay, so that's really the logic behind it. How about safety in general when it comes to stem cells? I think I would suspect, and a lot of our jobs are dealing with doctor questions, right? Physicians have all kinds of questions. So how can we describe safety overall when it comes to MSCs?
So again, as I mentioned, analysis of the data from the RA study and like a cohort of other studies in different indications, autoimmune diseases, neurological diseases, COVID and all that. So they have always been they have always demonstrated a safety profiling. Also, we had data as a mom myself. I would I can imagine the concerns parents might have in enrolling their children in a clinical trial, but we have done 2 single patient pediatric studies as well, in addition to all these adult studies I've been talking about. So there was one 13-year-old child with cerebral palsy, and the other one was the little 2-year-old with CMD. They got like several different infusions over the course of their studies, and then safety as has been a priority for us always. We have never seen any safety concerns. The only adverse effects that were observed, they were mild. Like again, as we were talking, and Michelle was pointing, and we were talking about earlier, those were like mild reactions, like flu-like symptoms, headaches, things like that, which can be just resolved very quickly. So I've not seen safety across all these studies I have ever analyzed the safety data for.
And after every infusion, we will be following up with the participant and their parent in 24 hours after the infusion, and then again at 72 hours to make sure that every participant is doing as well as he or she can. And if there's any issues, we have no problem you contacting us. We give you discharge papers during every infusion that has our contact information, so that if you have any questions or think, oh my gosh, my child has this, can this be a reaction? Reach out to us. We have no problem with that, and that's why we give that to you.
Do you see the stem cells having any issues with medications that the child might be on?
I do not. We have done several studies already with autoimmune, such as rheumatoid arthritis, and we've never had a reaction with any type of medication as of now.
What would be the primary concerns of a parent?
I would say safety. At the end of the day, we all want our kids to be safe. We would not have even thought about conducting this trial, in my opinion, if we thought there was a risk. We never want to put any child in harm's way. That is, we're trying to do the opposite. And then also travel. I mean, like I said, I have a 2.5-year-old, and travel can be in interesting times, especially if you're flying more than just a couple hours, especially a child that has an illness. So that's why we're trying to make this as easy and as accessible as we possibly can.
So when it comes to travel and coming here, what is you have to take all bias out of this, but what is the experience like coming here and participating in a trial? And
honestly, I can say it's nothing like I've ever experienced. And I've had several patients, they show up and they say, oh my gosh, they expect us all to be wearing this, lab coats and goggles and masks. And our facility is beautiful. We are right on a lake, so the view is beautiful. It's relaxing. We have snacks and drinks, and for the kids, we'll have coloring books and games and things like that to keep them entertained. So we want to make it as least scary as we possibly can. We want them to feel like they're joining our Hope family at the end of the day, and we want to make sure that they're happy here.
I completely forgot to describe how are the stem cells delivered? Like, how are these kiddos going to receive this medicine?
Yes. So it will be intravenously. So our clinical team will need to insert an IV. Luckily, we are very comfortable with pediatric patients. I've been working with them since the beginning of my career, so over a decade. I'm very comfortable starting intravenous IVs, and so is the other clinical team members. And we're also pediatric certified, and if there's any type of reaction, say that the child does, we don't expect it to happen, but we are prepared if there is an allergic reaction, and we are, myself and the RN are both pediatric certified to take care of those situations.
What do you do as a parent if you approach your doctor about this trial and they quickly dismiss it? What do you do? Where do you find information? What do you do in a situation like that?
So in this situation, like I said, we have no problem having a video call or a phone call with anybody's physician, parent, rheumatologist. We are happy to answer all and any questions. We will go through the protocol with any physician and explain our product and just answer any questions and try to put your mind at ease as best as we can.
I would try to see if they are like in the safe hands, which I can assure the staff here is very friendly and they are certified, experienced. So I think that is the assurance a parent would like to have before actually having a treatment done for their children.
And I think in this like post-COVID era that we're living in, where I know as mom, I was also very challenged with this, the whole vaccination question, and so no matter what side of it you're on, it's the digestion of information,
right,
and careful review of it. And I think as long as your doctor is willing to look at that, we're happy to provide any kind of data and safety data so that they can really get an objective view on a trial like this. In any situation you want to measure, I know that FDA operates this way too, on like risk versus benefit. And so what do you guys think? Do you, like when you're trying to think about what would this be a option for my child? What would go through your head?
So I would say, like the current conventional therapies in context of JIA, what children have, they comes with a lot of like side effects and other sort of like things. So I would say MSCs, treatment with MSCs would offer a safe treatment option. And if we talk about the potential benefits, I think they strongly outweigh, as at least from our RA data, they strongly outweigh the minimal risks which we saw in our adult population.
Yeah, I mean, every parent at the end of the day wants their kid to be as happy and healthy as possible. And I know we're all moms here, and we would do anything to make sure that our kid can run around on the playground and play sports with their peers. And unfortunately, these kids can't. And that's why we want to make this accessible, and we'll speak to whoever you need us to speak to and try to answer your questions and just make this process seamless.
Yeah, so one thing about the cells I just want to add in is, they are the primary mechanism that we have observed is their ability to mitigate the immune system and regulate it. And by doing so, you control this environment of the child's own immune system attacking itself. At the same time, this adjustment of the immune system in our observation has also led to just a higher immune system function in general. That really changes their lives, especially when it comes to exposure and risk of getting infections and things which we're always afraid of when we're on a lot of like immunosuppressants or those sorts of classes of medications. So with all bias aside, I would, with any clinical trial, there is always risk. I think that we always have to make clear, that is clear in our consents. At the same time, this is what I would consider a very low risk, potentially high reward situation. If the immune system responds to the cells, then it should respond in a very favorable way. Yeah.
Agreed.
Yeah. Yep. Well, any last thoughts? What's the most important thing to consider in a clinical trial?
For me, it's patient safety.
Okay.
We do everything in our power, make sure all of our certifications are up to board, that we are up to date on all the newest research and assessments to make sure that not just JIA, but every clinical trial that we conduct here, that the patients stay as safe as possible.
Yeah, so efficacy apart, I think whenever we design any of our clinical trials, our primary endpoints, they are always safety. So safety is our topmost priority for holding any clinical trial, be it adults or in children. So I think safety is the most important criteria that we'll keep in mind.
If anyone has questions, please give us a call. One of us will help answer for sure.
You can go to our website. Feel free to email us, call us. We're happy to answer all your questions.
All right. Okay. Thanks, ladies.
Thank you.
Thank you.